And this was a randomized trial that looked at FOLFIRI plus cetuximab versus FOLFIRI alone. And the primary endpoint, progression-free survival, this was a negative study, but this was really a critically important study. And I think is one of the main learning lessons that we can take away for how we should design trials in the future, is that they collected molecular data specifically on KRAS, and now all of us know that KRAS is clearly associated with one's response to cetuximab. And although this study was negative, quote unquote, it showed us that in those patients who are KRAS wild type, only those patients will respond to cetuximab, and treating patients who are mutant KRAS with cetuximab has no therapeutic benefit. I want to end on some very exciting data that has recently been published by the group from Bert Vogelstein and Luis Diaz at Johns Hopkins. I think this is really going to be the wave of the future. Everything that I've talked about so far has been this model. Whether it is a tumor inside a patient or a tumor that's outside a patient in the path lab, we specifically are sampling part of the tumor by either biopsying it or looking at only a portion of it. And therefore, there has been criticism that there is significant molecular heterogeneity of the tumor, and we may be missing this. And I think one of the revolutionary things that Bert Vogelstein has begun to look at is to look at naked circulating DNA. So rather than looking at DNA within the cells in the tumor, to look at naked plasma DNA, which probably more closely represents the true microenvironment of the tumor systemically and the risk of someone's recurrence. And this also allows, since it's free, to assess the true pool of DNA, mutant DNA within the patient. Now, this has been very, very challenging to do. But in this study, what they did is they biopsied the tumor and did direct sequencing of the cancer in the metastasis, but then they also drew plasma, and through this novel technique called beaming, they were able to amplify the circulating naked DNA and then specifically quantitate and identify those mutations in the circulating naked DNA. And basically, what they found is the following. Here is a representative beaming fax, if you will. Right here represents the mutant DNA. This is the sample of plasma on the patient before the tumor is taken out. This is the sample of plasma of the patient taken 3 days after the operation. So you can see here there's a small amount of mutant naked DNA still persistent. This is another plasma sample taken at 50 days after the operation with no clinical evidence of recurrence, but clearly an upregulation of this mutant circulating DNA. And here's a plasma sample 230 days after resection with a clinical recurrence and a significantly higher amount of circulating mutant DNA. The mutant DNA roughly has a half-life of 114 minutes, so one would expect within a couple days it should be completely gone. And what they found was actually quite stunning. They found that in those patients who had undetectable mutant naked circulating DNA postoperatively on day 3, that those patients had no recurrence. However, if any circulating DNA was able to be detected, all of those patients eventually recurred. So this is very exciting. So it holds potentially the prospect of almost real-time analysis of one's plasma to analyze one's the naked mutant DNA and to be able to predict whether a patient is going to recur in the future almost at the time of operation. In addition, looking at the plasma DNA, the actual mutations are able to be identified. So not only perhaps can we predict recurrence to plan additional therapy, but by looking at this plasma mutant DNA, we may be able to identify the actual mutations to tailor therapy. So finally, what does the future hold? Well, I think for hepatocellular carcinoma, this idea that molecular genomics can take us beyond the Milan and UCS criteria, and we can begin to use molecular signatures both in the tumor and the non-tumorous liver, and that we can begin to target therapy, whether it be with sorafenib, bevacizumab, or lotinib, based on loss of heterozygosity of specific chromosomes or microsatellites or allelic imbalance. I think with hepatic colorectal metastases, what I've tried to show is that we should be moving from morphologic criteria such as size and number to response to therapy, which I think right now is the current state of the art for the biologic prediction of how a patient's going to do. But very close on the horizon are these molecular determinants. And I think that we need to take a lesson from the whole KRAS cetuximab story, and when we prospectively are doing these trials, that we need to keep biologic and molecular correlates, because clearly our therapy will need to be tailored to the genetic mutations that are present in these tumors. And then finally, I think these very provocative data out of Bert Vogelstein's lab may suggest that we could base therapy on real-time analysis of this naked circulating DNA and perhaps tailor therapy to the mutations in the naked DNA that is circulating in the plasma and not in the tumor itself. So with that, I'll end, and thank you very much.
Thank you, Oscar, Clark, Scott, and Mark. Thanks for inviting me to give this talk. So we're talking about another ablation modality, or at least two different ablation modalities, and David's going to follow with microwave ablation. There's got to be something to the fact that we're still talking about ablation 10 years after we started talking about ablation, and that the fact is that we really can't resect the majority of tumors that come our way. There's very clearly diseases where potentially ablating a tumor in the liver or ablating soft tissue in consolidation with other chemotherapy or other oncologic treatments may hold a benefit for the patient. Nobody's really proven that yet. So what we bring to you is the new technologies and the results of some of these modalities that are being used, and we'll let you decide for yourselves where they fit into your armamentarium. So monopolar RFA is what you're all used to using. Single needle, different amplitude and energy than your Bovie cautery that you use. And the problem with monopolar energy is that you're putting a grounding pad on the thigh, or two of them, and you're sticking a needle into the tumor in the liver, and the energy is coming out of the generator. It's a very long distance, so it's very inefficient. Now I say that, and what does that mean? Well, let me tell you what that means. When you look at a monopolar thermal map, what you're looking here at each of these diamonds is an independent area of thermal energy coming out. And traditional monopolar RFA relies on these areas of dark burnt orange, which is the hot point, merging with each other. And what happens is that as you provide heat into an area, you desiccate the tissue, there is no electrolytic vibration, there is an increase in a thermal diffusion gradient, and that's a fancy word for saying that the energy doesn't come across and the heat slows down. And that's why after your 8 minutes of burn, you turn the button back on again, and you burn it for another 8 minutes. And if you really, really want to be sure, you cycle it through again. But even then, you're relatively unsure, and there's really no way to prove that you have, in fact, completely ablated the entire lesion. So the thermal map that I just showed you is of a typical projection tine map, and monopolar comes in straight needles. It comes in various tine maps coming out at different angles. And in theory, you should be able to conform the type of burn that you're going to create based on the array that you're going to generate. So in response to surgeon need and surgeon advice of what kinds of needles we needed to put them in different places, there has been an evolution of the shapes of the needles that are available to us, but nonetheless, these are still monopolar devices. So what is bipolar? Well, bipolar is actually quite simple.